Thank you. Hello, everybody, and welcome to the third of our webinars that we're running as a CSF Leak Association charity. And the webinars are really looking at the patient journey in having the spontaneous leak. And what we're looking at today is the third in that series, which will be looking at imaging. I'm Bernadette Hard. I'm a trustee in the CSF Leak Association, and the main charitable aims include supporting patients to access swift diagnosis and effective treatment for any individuals that are suffering with a leak. Whether you're joining us live or catching us on the recording, we're really pleased to have you all here today. In this webinar, as I said, we're looking at imaging, and we've got some UK-based experts here to join us. I'll hand over to Indran Davagnanam, who is giving our talk today. So Indran is a neuroradiologist who works in the National Hospital for Neurology and Neuroscience in Queen Square, London, and he has a special interest in diagnosing and interventional management of CSF leak disorders. So it's a great honour to hand over to Indran now so that we can hear his talk.
Thank you, Bern. Just going to start my slides. Right. Can you hear me okay? Good. Thank you very much for the kind introduction and the invitation to actually speak to yourselves this fine Saturday. As Bern said, I'm Indran. I'm a consultant neuroradiologist, and I'm based at the National Hospital for Neurology and Neurosurgery. I'm also an associate professor at the UCL Institute of Neurology. And today we are going to touch very briefly on the imaging of CSF leak disorders. The primary focus here is really to talk about spontaneous intracranial hypotension. So it's slightly biased towards spontaneous leaks. And diagnostic imaging, as I would put it, is key in establishing a diagnosis of CSF leaks, in isolating the site of a CSF leak. And of course, once you treat someone, it's also pivotal in the assessment of a treatment response. Not very long ago, myself and a group of other experts in the country had formulated some strategies to try and guide practitioners in this country to how to manage patients who present with spontaneous intracranial hypotension. And they're sort of dichotomized into two sort of aspects, but suffice it to say that the orange boxes are the points at which imaging plays a pivotal role in trying to sort of formulate a program of management and to take things forward. But before we actually start on the nitty-gritty of imaging, it's always worthwhile just revising what we know now about the different types of leak. So there are different sort of categorizations of CSF leaks, but I tend to use a very pragmatic sort of three-type leak approach. So as you know, type 1 leaks are what we call ventral leaks, or happening in front of the dura, and it's thought to be arising from wear and tear of the spine that causes a piercing or a degeneration of the lining of the dura that results in these longitudinally extensive spinal collections which are in front of the dural interface. So that's your typical type 1 leak. Type 2 leaks really are thought to be due to a vulnerability of that lining of the dura as it extends along the nerve root sheath. So you can see the lining actually extending some way along the nerve root, and at the points of vulnerability, they tend to rupture. The actual morphology on MRI imaging will vary according to how large the rent in the dura is, and obviously the flow dynamics and the reabsorption of the fluid in that region. So at times it can be quite challenging to isolate any pooling of CSF in that region. And of course, in more recent times, there's a clear recognition of CSF venous fistulae. So instead of that rent in the nerve root sleeve, accumulating fluid around the nerve root sleeve, what happens is there's an upregulation of drainage through the adjacent veins. And what happens is CSF then goes from the CSF system directly into the vascular systemic system. And it's thought that things like meningeal diverticuli are points of vulnerability, which are prone to rupture. So going back to our schematic, in terms of establishing a diagnosis of a CSF leak, there are two essential components. What I would term clinical phenotyping, this is the clinical assessment at first presentation, and diagnostic imaging. The trouble with just thinking about clinical phenotyping is that it's not absolute. So I'm reliant and maybe slightly privileged to actually work with headache neurologists who are specialized in this field. And even they struggle with the presentation phenotype. It's quite important to note that not all orthostatic symptoms are due to CSF leaks, and I'm sure my colleague Dr. Kima would have spoken to you about this in a past webinar. So the key here is for the headache neurologist to exclude all other non-leak causes, but that can be a highly challenging and complex process. In our previous publication earlier last year, we showed that the clinical phenotype can vary, and although headaches are a predominant feature, the character of the headache can be quite varied, as are the other symptoms that you get. So you can see here in the first box, there are differing percentages of presentation. And along with that, there are a myriad of different mimics for CSF leaks, not least POTS, migraine, cervicogenic headache, and primary new daily persistent headache, which are not associated with CSF leaks. So when we come to imaging investigations, what is the purpose? Well, the first reason to image is really to provide confirmatory evidence. So I would say that establishing a diagnosis of low pressure really provides confirmatory evidence of a potential CSF leak. And the way we do that is that we scan the brain and spinal cord by using very, very specific sequences. So the typical sequences that we perform are a brain and whole spine sort of MRI with contrast. And we utilize these high resolution steady state acquisitions of the spine. The premise for these imaging findings on MRI is based on a hypothesis that was generated in the 1700s by Monro. This is known as the Monro-Kelly hypothesis. And what essentially that encompasses is a closed box theory. So within the closed box, which is your cranium, you have differing components which occupy space. So all of those components are in some form of equilibrium. And if you develop a CSF leak, as you see here in the lower box, what happens is that the diminution of that volume within that one compartment, i.e. CSF, results in a compensatory mechanism of the other compartments taking or occupying that space. So as brain tissue is minimally compliant and arterial flow is somewhat regulated by the autonomic system, therefore, it is down to the venous system to then compensate for that loss of volume or space. So what happens thereafter is that we are left with things like dural thickening, which is essentially hyperemia of the dura. That's congestion, venous congestion of the dura, which causes it to be thick. Now, enhancement in itself is not pathological because the dura does enhance, but the thickening is. So when it's disproportionate and it's smooth and thickened, that is one of the signs. And that's not just limited to the intracranial compartment. We can see that it also encompasses the intraspinal compartment. So you can see some thickening and congestion of the dura in the front end of the cervical spine here and at the lower end of the lumbar spine here. And you can see that enhancement and thickening of the dura on the cross-sectional views. In addition to that, we have venous engorgement. So you can see that the normal configuration of the superior sagittal sinus is one that is deltoid or triangular shape. You can see that it's all plumped up there. And again, that's not limited to the intracranial compartment. We can see that in the dorsal epidural space on the spinal MRIs, that there are lots of venous distension and a little bit of thickening because of that distension, because of hyperemia. Again, part of the Monro-Kelly hypothesis. And we can see that there is a lot of sagging, particularly in the posterior fossa compartment. CSF acts as a fluid medium to buoy the components or the structural, the neuroparenchymal structures. So once you lose volume, that buoyancy diminishes and you get this almost sagging type appearance. And you can see that in multiple planes on the intracranial scans. And you get these collections that result. So once you get that sagging from the brain, it creates space overlying it. The CSF volumes diminish, and therefore what happens is that you get collections, fluid collections that fill up the potential space within the dura, and they cause these fluid collections surrounding the brain parenchyma and sometimes in the spine. And sometimes it's quite difficult to try and distinguish these fluid collections from actual CSF leaks. So we sometimes describe this as a wet appearing sort of epidural space on some of our scans rather than a defined collection. What also happens is that some other structures which are outside the blood-brain barrier become hyperemic and they get congested. So as you can see here, the pituitary gland becomes slightly bulky and it extends into the suprasellar system. The suprasellar system diminishes in terms of its space, and you get this congestion around the pituitary gland, which is also a known sign. And of course, we are aware of superficial siderosis. Now, there are various different theories as to why superficial siderosis happens. It could be that because of the low volume, the bridging veins within the subarachnoid system rupture, and therefore it causes deposition of the byproducts of hemorrhage on the surfaces of the brain, usually in the inferior part of the cerebrum, that's the top part of the brain, or most commonly the compartment that's infratentorial, which is in direct connection with the rest of the spine. And of course, this can extend along the length of the spinal cord. You can see this almost pencil outline of the spinal cord as a result of superficial siderosis. Our colleagues at Cedars-Sinai in Los Angeles, Walter Shevink, has shown that over time, with persistent type 1 CSF leaks, there is an increased risk or probability of developing superficial siderosis, or the consequences of which is bibrachial myotrophy. So he's shown over a 20-year follow-up period that the probability of developing superficial siderosis increases over time up to the point where at 16 years of having a type 1 leak, one may develop a 60% risk of developing superficial siderosis. When we did an analysis of all the imaging findings, what we found is that diffuse pachymeningeal enhancement or dural enhancement was the most common, followed by venous engorgement. And these characteristics are often used in classification systems and scoring systems. Here's an example from our colleagues in Bern, Tom Dabrocki, who's now, I think, in Bern. And what he looked at was a differential score with all the imaging findings that we talked about, weighted to the most common ones in order to try and classify the likelihood of getting a positive myelographic result. A few things to actually talk about this particular score. So this was developed and published sort of in the late sort of 2018, 2019 period. And what is important here is that, and Tom Dabrocki himself acknowledged that they didn't take into consideration a lot of CSF venous fistulas because it was just being recognized and being diagnosed. So that they postulated in their paper that CSF venous fistulas would not have a very high Bern score, but from our own institutional experience, we see the complete opposite, where CSF venous fistulas actually have a very, very high Bern score, meaning to say that they have all these imaging findings more so than other types of leaks. So that's one caveat. And the other is that there are a lot of groups, a lot of practitioners out there who extrapolate the utility of the Bern score to say that it correlates with severity of symptoms or the type of leak, or, for example, the likelihood of treatment. To be absolutely clear, that the scoring system was developed initially as a stratification process to determine if one would have a positive myelographic result or not. And any other use really is not really validated in the literature or by research. Spinal imaging is quite important. There are lots of centers in the world who rely solely on brain imaging, but we know that with brain imaging, it can be quite variable in terms of how you score patients based on the Burn score. There is an element of subjectivity. And over time, with chronicity, the imaging findings within the brain can normalize. So that would either downregulate or downscore someone on the Burn score, or it may return to a completely normal looking scan. So we find that spine imaging is particularly helpful if you have, for example, a very large longitudinally extensive CSF collection. So looking for collections within the spine is critical in terms of the overall assessment. And it's useful from our perspective in terms of dichotomizing patients. So we have what we call SLEC positive and SLEC negative patients. Essentially, if you see a collection or you don't. If you see a collection, the likelihood is that you're dealing with a type 1 leak or a type 2 leak with a substantial sort of egress of CSF, which accumulates in the epidural soft tissues. And if you don't see a large collection, we class that as being SLEC negative, then really your scrutiny should really be looking for, you should really be looking for a type 2 or a type 3 leak. So it's actually really, really helpful in that regard in terms of dichotomizing patients into the next stage of treatment or investigation and how you would actually approach those investigations. And, meningeal diverticuli are quite apparent on MRI scans. And it really helps, particularly when you're doing decubitus myelography, to look at the predominant number or size of these meningeal diverticuli, then to approach it from that perspective. So the more diverticuli you have on one side or the larger they are, you would start off by looking at potential leaks or fistula on that side. So the next part of the imaging process is really leak localization. Okay, so once we've established and we've reaffirmed the suspicion of a CSF leak on imaging, which is the first part here, then it's about localization. And historically, there have been a lot of different modalities that have been involved in that process. Okay, we won't go through all of them, but we'll deal with the major ones that have been more recent, that have some utility. As we know, as we are aware in our systematic review, the majority of CSF leaks or CSF venous fistulae tend to happen within the thoracic spine. And that may be because of the sheer mechanical dynamics of the spine. If you look very carefully, the thoracic spine is both weight-bearing and provides a degree of motility. So it's a combination of what the cervical spine does and the lumbar spine does. It is also the only point where it has this long curvature in reverse. So the cervical spine does this curvature, the lumbar spine does that curvature, and this is the reverse. So biomechanically, there may be different forces that are exerted on the dura that's adjacent to it. But also, anatomically, the thoracic spine constitutes the longest segment of the spine. So statistically, it would follow that most leaks would happen there anyway. So it may be just that association. We don't use a lot of MR myelography, and there are two particular reasons why that's the case. It can be very useful, and you can see some utility to doing so. However, it does involve the off-label introduction of gadolinium into the intrathecal compartment. And it's well recognized that even at low doses, intrathecal gadolinium or any form of contrast agent can provoke seizures. But it appears to be that gadolinium has a lower threshold to provoke seizures. So we try and avoid that, certainly in our institution. It is quite good in terms of what we call contrast resolution, because we've got specific sequences to look at the egress of contrast from, for example, this meningeal diverticulum out into the soft tissues. But acquiring those images can take a long time. So what usually happens is that institutions will instill gadolinium contrast after doing the initial bout of imaging. They leave the patient for about 1 to 2 hours and then bring them back for another scan. And in total, the whole procedure will take, including the waiting time, will take several hours. What seems to be more mainstream for us and a lot of other institutions is what we would call dynamic CT myelography. And this is this is a very quick procedure for us to actually undertake. The downside is, of course, we have to use ionizing radiation, which is not ideal, but we do try and limit the dose. And of course, as a management and diagnostic step, we hope that it is a one-off procedure leading on to definitive treatment. CT myelography has a real advantage in that it is of a very high resolution. We're talking about less than a millimeter spatial resolution. So tiny leaks, for example, this particular type 1 leak can be visualized with some degree of certainty and accuracy, as you can see on the reformat. With the volumetric data set, because we acquire approximately 900 to 1,000 images each time we do a scan, they can be reconstructed in different planes, and we get a three-dimensional depiction of where things are as a result. And it's particularly good in terms of what we call type 1 leaks. As you can see here, the divergence of the contrast bolus as it goes into the thoracic spine. So this is our mainstay of investigation. What we do as a fallback position, if we're unsuccessful, is digital subtraction myelography. So some centers like Cedars-Sinai would use digital subtraction myelography primarily, and then CT myelography as a troubleshooting step. It is a particularly good type of examination, digital subtraction myelography, except for the fact that we are limited by the field of view. So we need to limit our scrutiny, for example, to just the thoracic spine because of the nature of the examination. What it involves is the same administration of contrast, but instead of using CT, we're using two orthogonally placed X-ray detectors, which will continuously screen as the contrast bolus is administered. Now, because we are looking at things in real time, we don't want the images to be affected by any form of movement or breathing. So it is quite common for patients to be done under general anesthetic, which adds some additional complexity and risk to the whole procedure. But in return, what you get is exquisite temporal resolution. And what I mean by temporal resolution, you see real-time egress of leaks, either fistulae in this case, or type 1 leaks, so ventral leaks, as in this case. But again, we are quite limited, and it happens under general anesthetic. The other downside is, of course, we don't get a cross-sectional depiction of what actually happens. But if you are, if we are fortunate, we get to see things in its true projection, and we confirm the diagnosis as such. So to try and drive home a few other sort of minor but salient points, I've got a few illustrative cases. So here we have a 21-year-old patient, a lady, who presented to us with typical orthostatic type symptoms. And we've got quite good imaging, MRI imaging studies, which shows that hyperemia. So you can see the plump nature of some of the dural sinuses, sagging of the posterior fossa, and obviously quite a large prominent pituitary gland. And you can see the sagging at the craniocervical junction. She had quite a large collection, longitudinally extensive, both ventral, so in front, and at the back within the epidural space. And you can see that on the cross-sectional views, where you've got these sleeves of CSF on both sides. And as we sort of scrutinize the spine, once we got to the lower thoracic region, on the left side, you can see that this large meningeodiverticulum was there. And therefore, that was, primarily the suspicion. But obviously, if you have a longitudinally extensive collection, you'd think about a type 1 leak, but potentially a type 2 leak from this meningeodiverticulum. And you can see that we've reconstructed the MRI scan to give you this virtual myelographic image, but certainly not a clear indicator of where the leak is. So as part of our management algorithm and our proposed algorithm for management, the next step would have been an epidural blood patch, which I administered under CT guidance. So you can see here access to the dorsal epidural space, and we infused quite a large volume of autologous blood, or her own blood. And she did respond. So, I've got her previous imaging at the bottom here and her more recent imaging at the top. And you can see that most of the signs had almost completely resolved. And symptomatically, she was absolutely fine. She was back to normal, carrying on with her usual day-to-day activities. And this is where imaging is actually really, really helpful, not just brain imaging, but spine imaging. And our colleagues in Freiburg have shown that epidural blood patching may give you symptomatic relief, but clear imaging signs of residual or unchanged CSF leakage. And that was published in 2023. So her repeat spine imaging showed the persistence of these epidural collections. And again, when we sort of got to the bottom end of things, we could still see that large meningeal diverticulum and these collections which were surrounding it. So what we then did was, as part of the algorithm, we went on to myelography. So we started off with a high index of suspicion for a type 1 leak, hence why she was positioned, as you can see here, in a slightly inclined position with the needle sort of in the lumbar region. But with the hope of actually trying to isolate a type 1 leak. So on the first run, we didn't see anything. So we turned her onto a site where the meningeal diverticulum was, this large meningeal diverticulum. And you can see that she's on her side. And you can see the diverticulum actually filling in. But the trouble was that we couldn't actually see where the leak was. So what happened thereafter is that once we filled the meningeal diverticulum, we turned her on a side, the opposite side to where the diverticulum was. And then we saw this strand of contrast that fed from the meningeal diverticulum into the epidural space right there. So as it turns out, it was a complex meningeal diverticulum. It had a little septum in between, which you can just about see here as this little shelf-like projection. So what was happening was that she was filling CSF into the meningeal diverticulum. It would go past the septum onto the other side and then drain out and leak into the epidural space, so slightly complex. So I took the opportunity then to access that point where it was leaking with a needle and injected some fibrin glue, and she was cured thereafter. So one of the success stories that we had, but a very, very complex filling and drain and leak process that we were seeing. Here's another case of a 41-year-old lady with fairly good signs of low pressure in the brain and no CSF collections that are apparent in terms of the sort of ventral and dorsal epidural spaces. But what we can see on the axial imaging, she had these little sort of pools of fluid around some of the nerve roots. So we undertook myelography, and the story was not as straightforward. So here is the right T8-9 level, where we can see this slightly complex meningeal diverticulum and this egress of contrast. And when we did our fancy reconstructions, we can see that the egress of contrast was heading downwards beyond the meningeal diverticulum. So potentially a type 2 leak. So, we were sort of fairly successful there. But then when we looked at the adjacent level, we could still see some egress of contrast heading down another smaller diverticulum, so another type 2 leak potentially. And then when we looked at the right side one level down, we could see that this funny opacification of a vessel that was just in front of the thecal sac. Okay, and if you followed that vessel, you could see it was leading to this slightly complex meningeal diverticulum. So another meningeal diverticulum here, which you can see, and then filling of some vessels on either side of it. So in addition to the two potential type 2 leaks, we had a potential CSF venous fistula as well. And on the contralateral side, even more subtle. So when we turned down to a left side, we could see these little filling vessels on the left T910, sort of complex meningeal diverticulum. And this is just to highlight that where there may be more than one potential source of leak in this particular in some patients. So it's always worthwhile actually looking very, very hard and to expect the unexpected. So we've got some publications again from our colleagues in Cedars-Sinai and in Germany who have actually shown that. And the last case I'd like to show you is something that we've done within the last year. It's a 34-year-old lady. No particular reason why they're all ladies, but these are quite good illustrative cases. Again, good imaging signs of low pressure. She presented with bilateral subdural collections. Now, she didn't actually have any headaches. What she did have was back pain. And when you looked at the spine, it was lower back pain. So when you look at the spine, she didn't really have any collections that we could see. Well, you could see that there was a bit of wear and tear in her lower lumbar region. And when you looked at the lower lumbar region, we had a good neurologist examine her, and she had what we would call radiculopathic symptoms, which were referable to the left L4 nerve root. So potentially something was pinching the left L4 nerve root. So L4 comes off at about this level where the red arrows are. So you can see a little disc there. And when you look in cross section, we can see the L4 nerve root, which I've highlighted with that arrow there. And it seems clear. It doesn't look like there's anything that's actually causing any compression. But when you look very closely on the parasagittal views, you can see that there's a little meningeal diverticulum there. And you can zoom in on that on the high resolution sequences. You can see it there. And it's just adjacent to the nerve root. So could that be causing some mass effect? But, clearly with the subdurals, one had to think about a CSF leak. But how do you tie both of them together? Well, when we did the myelogram, the cubitus myelogram, you can see that the meningeal diverticulum filled, and you had some egress of contrast through these channels. Okay, quite hard to work out what they were. So it could be a type 2 leak. But when we sort of amalgamated the data set, so we do what we call these maximal intensity projections, you can see these ramified structures. So this was a CSF venous fistula arising from that meningeal diverticulum at about the level of L4 on the left, causing radicular symptoms. I've done some fancy reconstructions here just to show that. So you can see the needle that's been put in, the meningeal diverticulum there, and then the filling of the veins on either side. Okay. So, just to illustrate the points that, these things can be unexpected in terms of presentation, in terms of number, in terms of how they actually leak. So you kind of have to preempt these things, not really go in with a set of expectations. So everything's really quite fluid, so to speak, forgive the pun. And just to finish off, there's a section that I always put into my talks called the retrospectoscope. And what it is I've been doing this with the headache group for about 11 years. And you learn quite a lot. Things have evolved quite remarkably. And as recent as our own guidelines, so we've got this schematic which outlines the guidelines, which is the algorithm which is proposed. And it's quickly becoming apparent that, there are ways to streamline this process. Now, this is unpublished as yet, and the data is there to support perhaps not really utilizing non-targeted blood patches to any degree. And it really depends because it really is quite variable in terms of the practice across the world. And part of the reason why that practice is variable is because setups are variable. So, for example, Cedars-Sinai is predominantly led by neurosurgery and supported by neuroradiologists. So they are predominantly DSM, but a very, very heavy surgical center. North Carolina, for example, is almost exclusively run by neuroradiologists. So they don't do a lot of surgery, and they're more or less exclusively fibrin injectors. But, given the full resources and a multidisciplinary approach to things, this is what I think should happen. So when you have a clinical suspicion and you phenotyped things to the point where you're fairly convinced that it might be a CSF leak, you do your confirmatory MRI scan, which will provide supportive evidence of a leak, and you try and isolate you try and categorize what type of leak it is. So if you've got a large fluid collection, then you're going to subject them to a prone DSM or CTM with a view to actually turning them decubitus if you don't find anything. Or if they're select negative, they don't have a collection, you'd start off with a decubitus myelogram. And on identification, you can then propose one of three potential steps for treatment, depending on what type of leak it is. So you can do target blood patches or fibrin injections, which probably are not as effective as surgery from our own series. Surgery, of course, is there, or in the case of CSF venous fistula, transvenous catheterization and embolization. Last section, just to finish up. If I knew then what I know now, you have to be patient. So it is often very disheartening for both the patient and the practitioner not to find something on first look, both on MRI and with myelography. So you have to be patient, you have to stay the course. And therefore persistence is a really good attribute. You have to expect the unexpected. So I showed you a few cases where, if we left it at where we thought things were going to end up, for example, with the big meningeal diverticulum, we wouldn't have found the leak until we turned them over, or we did some other maneuver. You have to mitigate expectation. Not everyone is a success story, and related to this is a lot of the publications will have that slight publication bias to say we're 100% will cure everything in sight. The reality is that we help a lot of patients, but there are a lot of patients who we struggle with. And it really, really helps when you have a multidisciplinary approach to things and everyone sort of puts their intellectual input into trying to help patients. And with that, it's always quite important to acknowledge the teams that we work with. So I'm very appreciative of the infrastructure that I have in terms of delivering the service. And of course, I'm very appreciative to the CSF Leak Association, who've been very supportive in both the guidelines and of course, inviting me here today. Thank you.
Thank you. Thank you so much, Indran, for sharing that really interesting talk with us. We've also now been joined by Paddy Nicholson, who is a colleague of yours and also an interventional neuroradiologist that's joining us actually from Dublin. So we've had some really good questions ahead of time. I think Paddy has some of those questions. So I'm actually going to hand over to Paddy now so that Paddy and Indran can perhaps discuss some of the questions that people have posed with Indran.
Very good. Thanks, Bern, excuse me, and thanks, Indran, for a fantastic talk. Beautiful images showing that you really need a multimodal approach to both diagnosing and treating these CSF leaks and helping patients. I'm going to jump right into a few questions. We kind of tagged them into some that might be more relevant for me as an imager to ask and see can Indran plus or minus myself give some insight. So the first question, is opacification of the maxillary sinus considered to be a rare or a more common finding in CSF leaks in 2024?
Yeah, really interesting question. I think there is some literature on this, but it's slightly clouded by the fact that some of the literature is from post-traumatic CSF leaks from the skull base. So in those instances, yes, it is directly associated because that's where the accumulation of CSF happens. But in the case of spontaneous leaks, what we found, certainly from our group practice, is that quite a lot of patients report CSF rhinorrhea, which is the fluid sort of pouring out the nose. And that may be because of a coexistent autonomic dysregulation process that happens with CSF leaks. Now, we're not quite sure what the mechanism is, but it is quite common. Now, on objective testing, it is almost invariably the case that these are negative for markers for CSF. So they're a epiphenomenon, so to speak. And no one's really explored how useful it is as a sign of a CSF leak. Of course, it's slightly difficult when you're in London and you're living in a polluted sort of city not to have some degree of sinusitis and a snotty nose. So it's quite difficult to try and disentangle the two. I don't know, Paddy, what's your experience of this?
Yeah, I fully agree. I think that for me, when I think about maxillary sinus opacification, it's post-traumatic or post-surgical skull-base leaks that I'm thinking of.
Yeah.
Usually the spinal, so to speak, the more common symptomatic intracranial hypotension due to a leak along the spine, for me, is not associated with maxillary sinus airspace opacification. And it's also clouded by the fact, as you pointed out, that the vast majority, not the vast majority, but a lot of people have incidental maxillary sinus mucosal opacification. I tell my residents and registrars, don't bother reporting it unless there's symptoms of, you know what I mean?
Yeah.
It's a very, very common finding. And some radiologists will report it and some radiologists won't. So in terms of iatrogenic or completely spontaneous CSF leaks, I don't really think about maxillary sinus opacification as a sign unless you're dealing with the post-surgical skull-base leak, which is much more rare.
Yes, agreed.
Okay, good. Now,
there's a question.
Oh yeah,
There's
sorry,
a question.
let's go for it, Bern.
Alternative, yeah. There's a question here which I think might be better coming from the kind of patient representative side, because it's more practical to either of you, really. Do you have a feel for how common it is where you get a partial repair for a leak having been fixed by a non-targeted blood patch, and maybe some of the symptoms have gone but the patient's not fully better, and what would be the next step for assessing that? I think Indran actually covered that to some extent in that patient case study, but it's a difficult area.
It is a difficult area. Do you mind if I start first, Paddy? I can just elaborate a little bit on what Bern said. So in that illustrative case is a prime example of how there can be a complete disconnect between how someone responds clinically and the persistence of a leak. And of course, with type 1 leaks, we know there are consequences of leaving a leak untreated. Added to that complexity is that non-targeted blood patches have a known placebo effect. And what I mean by that is that the administration, the actual process of administering the procedure can have a perceived benefit where there is none in pathophysiological terms. So we're not really curing anyone, it's not sealed anything, but patients can feel better. And that's quite widely acknowledged, not just for blood patching, but for other things like drug trials. So the best way to reassess, to answer the question, the best way to reassess is really a combined clinical and imaging protocol. And I would say that's almost a template for moving forward in any part of that management process, regardless if it's blood patching, if it's glue patching, if it's transvenous embolization, if it's surgery. I think it's a really, really good comprehensive way of actually making an assessment. Paddy?
Yeah, I fully agree. I think it has to be multimodal. I think that, I've had patients after embolization that the patient feels better, but the scan looks the same. And then I've had patients where the scan looks better, but the patient feels the same or the patient feels worse. So I tell patients that we'll see how you get on, and it's individual for every patient. It's not like when we're doing a myelogram and an embolization, you can say for sure the leak is gone, or even a glue injection. You can say, I think I've got it, and we'll have to see how you get on. But it really is, for me, dictated by patient symptoms. And patients can have everything from the brain fog and the cognitive dysfunction to the headache, to the postural component of the headache, all of the myriad debilitating symptoms. Even within that bucket, some patients can be like, well, my headache got better, but my brain fog got worse, or vice versa. For me, I find it very individualized to every patient, and there's certainly no one size fits all answer. So we try and be as objective as possible. We try and do the same imaging protocol before and after. I often ask patients to keep headache diaries, for example. I know there's a lot of work done on disability and quality of life scores and trying to quantify that response, but that's all more academic. For me, it's really down to how the patient feels, and to a lesser extent what the scan looks like.
Yeah.
Thank you. So we've actually had a question relating just exactly to the answers that you've both given, which is that this is a really tricky area and I guess requires individual case-by-case evaluation and evaluation of the imagery. This person's asked, if you repeat the MRI following a blood patch, and if that shows significant improvement and resolved fluid collection, but there's still a leak with different symptoms, so is that something that you see perhaps with patients that have got more than one leak site? Or
it is a slightly complex answer again. So there is a certain tempo to resolution. So what we found is if we did imaging at 3 months, let's say post blood patch, we would find that there may be partial resolution, both from imaging and clinically, but a proportion of patients will respond in the longer run to that. And it may be the case that the mechanism by which the blood patch works is it tips the balance. So it facilitates then your own healing. So we've attenuated the egress of CSF into the epidural space, and therefore, given time, that then completely seals it off, and it takes several months for it to happen. But similarly, there are situations where we've got patients who have complete resolution of a collection. They've got symptoms which have slightly evolved but very orthostatic. And then the general approach usually is an MDT approach, but the general approach is to start afresh and look for another cause for a CSF leak. So it may be a fistula, particularly in recognition that there may be more than one type of leak. Paddy?
Very challenging.
Yeah, I agree, Indran. And the other thing, which I think 10% ballpark of my patients have come back with, and I always warn them about after treatment, is that sometimes you can get rebound hypertension, so high pressure leak after treatment of a low pressure leak, which sounds ridiculous, but when you work it out, the brain is overproducing CSF in order to keep up with the leak, or certainly it's producing a set amount of CSF. So then when you plug that leak, the CSF production doesn't slow down for a while in a certain subset of patients. And it's fairly well recognized that these patients can come back with signs and symptoms of so-called intracranial hypertension rather than hypotension. The character of the headaches changes in these patients. So whereby the typical SI, and I'm not saying everybody has it, of course, but the so-called typical SIH headache is postural in particular. The patients who have rebound hypertension after a leak being treated will come back with often a feeling of fullness behind the eyes, a full nature to their headache. It doesn't have a postural component. Sometimes they might even have a pain or pressure down the back of their neck and or pulsatil tinnitus, or a ringing in the ears which is synchronous to their heartbeat. I've had a few patients come back with that, and it's often puzzling for patients that, well, my symptoms got better, but now I've got this headache and so on and so forth. So it's often something I warn patients is a possibility in the minority after treatment. And almost paradoxically, it means that the treatment has worked because we've plugged the leak. And I should say that will generally get better. If it doesn't, I tend to give them a drug called Diamox or acetazolamide for a few weeks to decrease that CSF pressure, then taper that off after a few weeks, and it will get better. But this is in the minority of patients. But I guess to summarize both myself and Indran's answer to that question, it's a very dynamic process. It's not like bang, you're cured. Some patients will get better sooner rather than later. Some patients will have a completely different headache afterwards and so on. So that's why, just like with the imaging and with the treatment, we have to tailor everything to the individual patient in front of us.
Thank you both. Paddy, are there some more questions there that are more technical in nature?
Yeah, there's one. Let me see. Can you explain how small perineural cysts can cause SIH? And if cysts are identified by MRI, what further imaging can be done to view these cysts in more detail? Well, Indran showed some beautiful pictures using high-resolution MRI of so-called perineural cysts. I presume the question is relating to meningeal diverticulae or perineural cysts, as opposed to Tarlov cysts, which you can see in the sacrum. The difficulty for me with the perineural cysts is that lots of patients who are not CSF leakers have perineural cysts. We know for sure there is some kind of an association, and we feel that some patients will spring a leak from one of these cysts. But just because a patient has cysts does not mean that they automatically have a CSF leak, or that is the site of the CSF leak. I have seen some anecdotal data presented at conferences suggesting that if patients have no or few meningeal diverticular or perineural cysts, that we find leaks in those patients less often. So for me, it just means that I look very closely at each and every one of those cysts. But just because you see a meningeal diverticulum or a perineural cyst there, that does not mean, as I said, the patient has a leak or that is the site of the leak. And in terms of imaging them in more detail, the imaging we have is pretty as good as we're going to get. We saw some beautiful high resolution CT. We're going to see photon CT, although we see photon counting CT, but it's only in a very small number of centers and kind of not very widespread commercially available yet. We saw some high resolution 3 Tesla MRI. I think that's all the imaging you need. I don't think like we're getting down to the millimetric level in these. So I don't foresee any fancy imaging techniques that will really change the game in terms of imaging these. But as I said, I don't necessarily think that we need to. Indran.
Yeah, no, I think that sort of comprehensively covers it. I think the takeaway points are they do happen in patients who don't have CSF leaks. The largest and most complex diverticulum is a site for suspicion, but not necessarily the site of leak. That one patient that I showed you at the end with that really odd CSF venous fistula, that was the only meningeal diverticulum she had. And it wasn't a very big one, but it was slightly complex, but, you know, very, very florid sort of enhancement of the paravertebral veins. So I think, you know, things evolve, but as of now, I think we're throwing everything at it in terms of just looking for these meningeal diverticuli. But in terms of taking things forward, in terms of further imaging, I'm not sure if it adds any further value. You know, moving on to myelography really is, for me, the next step. That's a much more dynamic process rather than a static image. So it can be very useful in terms of assessment, doing the myelography rather than post-processing or doing much more on the MRI scan.
Thank you. That's a really comprehensive explanation for that very tricky situation. There's a question that we had pre-webinar, which was in relation to a patient's blood pressure at the time of imaging, particularly if you're looking for a fistula. Does this make any difference, or actually there was the other aspect was whether it made a difference, whether how the patient was breathing, whether they were breathing in or out at the time? What are those kind of dynamic things?
Happy to start with that. There is a natural coupling process looking at systemic blood pressure, venous pressure, and CSF production and CSF dynamics. So CSF flow in itself is coupled indirectly to arterial and venous pulsation and drainage. So, for example, we do what's been promoted as resisted inspiration, which is essentially akin to trying to breathe through a very, very small straw. So taking a deep breath in. And what that has been purported to do is to increase the return of venous blood through the venous superior vena cava, this large conduit back into the heart, and therefore promote, if there is a point of escape of CSF into the venous system, promote that egress of contrast into the venous system. So there is some degree of coupling. Now, how that directly affects, for example, if you were to hypertense someone or make them give them high blood pressure, what is the overall effect on CSF flow? It's difficult to know. There are intrinsic mechanisms for finely regulating each, which will then cause a compensatory reduction at some point. So it's all great when you're actually doing a maneuver for a myelogram for that one point in time, but doing it in the long run, I suspect that the body will try and readdress or re-equilibrate that. Paddy, if you got anything to add to that?
Yeah, not much. I don't have anything to add. That's very comprehensive. You have a very deep understanding of this stuff, which I admire. From a more practical point of view, the resisted inspiration stuff has been a couple of papers out about it showing that some people feel that it does increase the rate of pickup of CSF venous fistulas on either regular digital subtraction myelogram, DSM, or CT myelogram. Some places do it, some places don't. I mean, I don't think it hurts, so I do it. But if I forgot to get a patient to do it, it doesn't. I don't think it means it's a negative myelogram or anything like that. So yeah, that's. But it's a different thing. The thoracic pressure is a very abrupt change in the pressure around the thecal sac and stuff like that, as opposed to systemic blood pressure, which is a more kind of a prolonged thing. So I think that it's a much more, the resisted inspiration or the forced Valsalva, reverse Valsalva is a much more kind of abrupt, short-lived approach, which can be useful.
Thank you. Yeah, just goes to show how technically challenging these imaging processes can be. That if anyone's in the audience and they weren't there at the beginning, just to say that if you do have any questions, you can pop them in the Q and answer and the Q&A section, and we can pick them up. Paddy, there was a few more technical questions, I think, that you might like to have a go at yourself and Indran.
Yeah. I'm going to kind of summarize one of the questions here, and if the questioner, please correct me if I'm wrong. So it asks, what considerations can you do to try and find a leak if you've got spinal hardware inside you? That can always be quite challenging, because obviously with an MRI, you can get a lot of susceptibility artifact from around say, for example, if you've got lumbar or thoracic fusion screws, you can get a lot of metallic artifact. So for me, that's when we use a combination of imaging. So I will generally start off with a digital subtraction myelogram, because you don't get a lot of, well, first of all, because I'm a neurointerventional radiologist, and like when you have a hammer, everything looks like a nail. But joking aside, you do get a lot less artifact with a DSM with live fluoroscopic images than you will from an MRI or from CT. And then if I'm unsure or stuck with the DSM, I will often bring the patient for usually a CT myelogram, and it's often a combination of the two. So again, and the theme of all my answers is that there's no one right answer for all of this stuff. We have to take an individual patient-centered approach, but that's unfortunately the case here. There's no one modality that will get you around it, so you have to use a combination of modalities depending on, I guess, where the hardware is and so on and so forth. Indran, any?
Yep. Completely agree. I mean, you can't build a house with just a screwdriver, can you? So, you know, it's that multimodal approach to it. Now, there's some fancy things that you can do post-processing wise with CT and MRI, what we call metallic artifact reduction, or MARS. The problem with that, for example, if you were to apply that with myelography, is that the algorithm reduces the streak artifact, the little attenuation or artifacts from the metalwork, but it sometimes removes the leaks, so it obscures it. So it can be a bit of a double-edged sword. So completely agree with Paddy. So multimodal approach is probably best.
Thank you. So that adds more complications. Yes.
Bern, there were some other questions in that spreadsheet. Where the ones that don't have BH beside them, are they for you, just for clarity?
BH ones were more for me, and any
Perfect.
of the others for you to pick up. So go ahead, pick another one.
Yeah, no, I'm just making sure that I haven't missed anybody here. Can you explain how an acute and chronic subdural hematoma can result from a CSF leak? And is this something you can see quite often? You can, of course, get chronic and even acute subdural hematomas. And Indran kind of covered it. No, he didn't kind of. He did cover it well in his talk. It's due to the Monro-Kelly effect, whereby you've got a decrease in CSF pressure and it separates out those layers of dura and fluid goes in to fill that. I have seen one patient I had in Toronto who even had an acute subdural hematoma and was quite unwell from that. So that's really the edge case in terms of in terms of CSF leak, like the severe end of the spectrum. One interesting point, though, is that if I see, I was talking to the neurosurgeons about this lately in my hospital, if you see bilateral chronic subdurals that are non-traumatic in a young person, for sure, anybody less than 60 or 50 years of age, then you need to evaluate the brain for other signs of CSF leak, and you need to evaluate the patient for signs of postural headache and or all of the other signs of SIH. Same thing with a so-called Chiari malformation, where you can get tonsillar descent, but that can commonly, and I suspect in the past, many of these patients were mistaken for having a so-called Chiari malformation. So for me, any of those signs, I often, that's just a reminder for me to check the brain for other signs of spontaneous intracranial hypotension. Indran?
Yeah, no, absolutely agree. And on the note of Chiari, we've had 2 patients at least who've had surgery for Chiari who, when you looked very closely, had other signs of low pressure. And when we did myelography on them, had definite CSF venous fistulae, which were treated.
Yeah, I've seen 1 or 2 patients. Same. Yeah. And on that, like, and Indran kind of touched on this as well. I often have patients and they're like, oh my God, how come this wasn't seen on my previous imaging? This stuff is super subtle, super hard. Like myself and Indran, and many of the others in the UK and Ireland who specialize in the imaging and treatment of CSF leaks. It's an important thing to remember is we're often unsure, and I often have to text colleagues to say, what do you think of this? And we show each other cases, including at conferences and stuff. And this is stuff that we do all day, every day. For the general radiologists working in non-neuro hospitals and even in neuro hospitals, unless this stuff is fresh in your brain and unless you're thinking about it and keeping an eye out for it and really guided by the clinical symptoms, it's very, very difficult. So I would never begrudge colleagues in other hospitals. And I often have to explain to patients that when we say, oh, well, this was missed in another hospital, this is super subtle, it can be super subtle, super hard stuff. So it's difficult. And I hope we're getting across that in this webinar.
Yeah, absolutely echo that actually, Paddy. Definitely.
So we've had one question just come up in the Q&A section about the sciatic nerve compression. So this participant referenced the fact that Indran mentioned a case of a leak around a nerve root in the lumbar spine, and wondered whether you can see leaks associated with sciatic nerve compression.
It's not usually the case. I mean, this is the first case that I've ever seen in the 11 years that we've been doing this. So it is highly unusual. Plus, not to forget that she had quite good intracranial or brain imaging signs of a leak. So I think there was sufficient justification there to look very carefully and at a potential cause for sciatic symptoms. What's common is, sciatic symptoms resulting from degeneration of the spine, and that's far commoner than having a CSF venous fistula actually causing radicular or sciatic type symptoms.
Got it. Okay. So I think that's all of the questions that we were hoping to address live today. Any more that you can see there, Paddy?
Yeah, there's just one question about the so-called dinosaur. It's just come in 3 minutes ago. The so-called dinosaur tail sign on a spinal MRI. I had to look this up because, and then I remember hearing about it. This is a very, I wouldn't say it's particularly commonly used. There was a couple of case reports about it in 2017, 2018, and it basically relates to the nature or the shape of the edema between the interspinous processes on the sagittal T2 weighted imaging of a spinal MRI. But to be honest, I don't use it. I don't teach it to people when I'm giving lectures on this. I haven't seen it commonly used in CSF leak talks. That's not to say it's not a valuable sign, but the more you go into the radiology literature, there's about 1 million signs that people describe in papers, and only the commonly used ones kind of tend to gain traction. So just because I don't know about it doesn't mean it's a bad sign, but I don't expect to see it commonly used in reports or talks or anything like that. Indran, have you ever seen or used the dinosaur tail sign in a report?
First I've heard of it, and no, I don't use it.
I was able to do some fast Googling there.
Yeah. No, very good, very good.
So there's just a few more questions that have just come in the last few minutes. Somebody's asked, does superficial siderosis show on the usual scans that would be done for leaks, or would we need to look specifically for that using different imaging if we were suspecting it?
If you were to do a comprehensive protocol to looking for a leak, it is part of the suggestion for that we've proposed, but an ordinary or routine sort of brain or spine scan would not necessarily have the right component sequences to look for it or detect it, because it can be quite subtle.
That's worth knowing, isn't it? Yeah. Okay. And another question that just came in, someone said, I understand how rare it is and how hard to identify, but when it's suspected in A&E, should an MRI be performed? I guess thinking about a potential leak, or should that MRI imaging be done once there's been a specialist team referral? Really just thinking about the kind of sequence of investigation that the patient would benefit from pragmatically at the time.
For me, I think that it's a great question. I think it depends on what resource kind of setting you're working in, what kind of hospital, what country you're in, and so forth. For example, in any of the hospitals I've worked in publicly, as in any of the public hospitals, I don't think we would routinely do a brain and spine MRI for a suspected CSF leak, simply because of the resource constraints. I mean, it's difficult enough to get an MRI for a patient from A&E if they've got suspected cauda equina, which is a true neurosurgical emergency. You're trying to do it with all of the other elective stuff. So personally, I haven't seen it requested from our ED physicians and colleagues. I think that the vast majority of this stuff, in my experience, comes from specialist teams, because the patient is usually worked up by headache or CSF leak specialists and so on. That's not to say it couldn't happen. For example, if a patient comes in, as I described earlier, with like spontaneous subdural hygromas or something like that, then it is possible we would do it in that situation. But for me, it's generally a secondary referral rather than from the emergency department. Indran, do you get a lot of referrals for CSF leak from the ED?
No, not particularly, but I've just got to be slightly cautious here. So the purpose of the guidelines that we proposed and published was really to try and do one of two things really: educate our colleagues. So that was published in the medical journals to really raise awareness of this, and the idea behind it really was to have at least for clinicians to recognize it, because I think recognizing the entity and recognizing the clinical and imaging signs is the first step. So I agree that our emergency physicians aren't really the appropriate first step, but in terms of recognition, at least an onward referral to even the local neurologist could set about that correct management pathway. And I think the fear was in the past, and I think it still is a fear, that we're delaying the diagnosis to the point where things are, become slightly more complex, and patients are left to actually, deal with the consequences of this for many, many months, if not years. So recognition means that the appropriate pathways can be put in place. So, maybe not an MRI scan at the time of presentation, but shortly after, to look for signs of it, and then, if appropriate, an onward referral to a specialist center. And if you do indulge in a bit of reading, and if you look through the guidelines, I think that the purpose of the guidelines and the algorithm was precisely that: raise awareness, look for the signs and symptoms, do the appropriate imaging, and then and probably then refer on to a specialist center.
So just one final query for you both, very much on topic here, that someone else has just posed. In hospitals new to CSF leak patients, how can patients ensure that they receive the right imaging? Can it be assumed that the hospital or the treating team will be aware of the guidelines? I certainly have a view on that, but I'm going to let you guys go first.
Yeah, I can start. I think, it's an ongoing process, isn't it? Education is an ongoing process. And, Bern, you've done your bit, and, and the societies, the associations have done their bits. And we have, as a group, we've published, we've done podcasts, and the similar groups across the world have done exactly the same. And for all best intentions, it's not 100%. That knowledge base hasn't sort of filtered through to all aspects of medical healthcare. So there's always going to be an element of people not recognizing it. So it's difficult to ensure that you get the right people with the right thought process doing the right things as a next step. But hopefully, with time, that will become sort of fairly mainstream. Paddy?
Sorry, unmuting myself. Fully agree. It's a recognition thing. There's no right answer. Is everybody aware of the guidelines? Absolutely not. I can tell you that not even all neuro specialists are aware of the up-to-date guidelines. So all I can do is echo what Indran has said and appreciate the work that this society and other societies have done in getting the word out there to patients and to physicians. If you're a patient and you think you have a CSF leak, I would not be shy about advocating for yourself. If you're talking to your family doctor, your GP, or even your general neurologist who might not be aware of the guidelines, if a patient brings up guidelines or literature that I'm not aware of, I will absolutely thank them, have a read, and try and educate myself. So it's an ongoing process. There's no right answer, but we're getting there.
Yeah, I mean, I think I would just echo that. I'm a GP, not a CSF leak specialist, but from a medical background, and obviously trustee of the CSF Leak Association and a leak patient myself. And I think that this speaks to the fact that, you know, with the increasing complexity generally in medicine, it's really impossible for everyone to be fully up to date on everything that's coming out. But also because us as patients have got access now to, you know, AI and ChatGTP, and also charities like this that are trying to give out information. Information is not now the purview of the specialists. It's there for everybody, and co-production is really, really important. So, you know, we should feel confident in politely suggesting to our doctors that we've also done some research, and perhaps we wouldn't be expected to interpret that research from a layperson's perspective, but that voice is really important. And hopefully the work that the charity does in trying to disseminate and to gather and to present information in a simple way gives you a tool. So, you know, if you're a patient and you're in this position, I think I would echo what these two people have said here today, which is, yes, by all means, take that information along and open a conversation in a kind of, you know, a collaborative way as best as possible. I think that's generally well received. I'd hope it would be. So I think that's probably all of our questions addressed. If there are themes that have come in since, what we'll do is we'll go through them after the webinar, and we will look to, well, obviously we'll publish the webinar on YouTube and on the website, but we'll also try and address any themes that weren't answered today by our experts. So that leaves myself to thank everybody for turning up and supporting us with this webinar on a Saturday afternoon, and also my deepest gratitude to Giving Up. Both of these doctors have been working today, so they've actually had to fit this in on their Saturday alongside of their clinical work. So we're really, really grateful for that. They donated their time very, very willingly to us. So both Paddy Nicholson and Indran Davagnanam, massively grateful on the behalf of the charity and the community for your time and your expertise that you've shared with us today.
Thank you.
Thanks, Bern. Our pleasure.
So